In this module on pediatric anesthesia, we will be discussing common interventions in the pediatric age group. Children form a different group of patients than adults, and this requires modifications in the routine anesthesia management in children. This module tends to discuss anesthesia aspects in children undergoing a variety of surgical procedures. This module will consist of 4 lectures, and this lecture will discuss the airway management in children and anesthesia for children with cleft lip and palate. Airway management forms an important aspect of anesthesia and for an anesthesiologist, and this requires an understanding of the differences in the management of a child's airway compared to an adult. The airway management in children is generally straightforward for anesthesiologists who are usually anesthetizing children in their day-to-day practices and performing about 200 cases per year. However, for an occasional pediatric anesthesiologist who administers anesthesia to children very infrequently, the airway management can be problematic. It has been found that anesthesiologists who perform less than 100 pediatric cases per year are 5 times more likely to experience complications during the airway management of children. The size, weight, anatomy, and physiology of a child is very different compared to an adult, and failure to modify the management appropriate to the age of the child can lead to airway complications like loss of airway and failed ventilation. According to the closed claim analysis and the POCA registry, the main reasons for cardiac arrest and brain death in pediatric patients are airway problems. It has been found by the POCA registry that the incidence of perioperative cardiac arrests in 27% of the cases is due to respiratory events like airway obstruction due to laryngospasm, inadequate ventilation or oxygenation, difficult intubation, and esophageal or endobronchial intubation. Also, the perioperative mortality is much higher in children than adults. The risk of airway complications and respiratory failure are more common in children up to 2 years of age because of increased parasympathetic tone. Their brain is immature, their respiratory center is underdeveloped, and they have altered behavioral responses. These children also carry an increased risk of hypoxia because of limited respiratory reserve. This is because that the metabolic rate is double that of adults. They have less number of alveoli so that they have 26 times less area for gas exchange. Their tidal volume, regardless of age, is 8 ml per kg, thereby meaning that it is only 24 ml for a 3 kg infant. The FRC is lower, and since FRC is lungs respiratory reserve, it makes the infants unable to hold breath for a longer time. Also, they have a higher dead space versus adults, and therefore less tidal volume is available for ventilating the alveoli. Therefore, infants need higher respiratory rate and heart rate to compensate for the smaller tidal volumes, larger dead space, as well as higher oxygen consumption and carbon dioxide production. In adults, hypoxia triggers a sympathetic response leading to tachycardia, which improves oxygen delivery. Bradycardia is a late sign of imminent cardiovascular collapse. Bradycardia is the first sign of hypoxia in small children because their brain is immature and they have a better developed parasympathetic system. In addition, their cardiac output is rate dependent. Bradycardia lowers the cardiac output and worsens oxygen delivery as well as hypoxia and hypercarbia. The developing acidosis depresses the myocardium, leading to cardiac arrest. Because of incomplete nerve myelination, a poorly developed blood-brain barrier, immature CNS, and relative lack of exposure to drugs makes the children prone to respiratory depression and apnea when administered even small doses of pain relieving medications. This is particularly true for premature infants up to 6 weeks of post conceptual age who are likely to develop periodic breathing and apnea, especially after exposure to general anesthesia. Let me take you through the preoperative assessment of a 1.5-year-old 12 kg child who is posted for lap pyeloplasty. These children, during the preoperative assessment, in addition to the routine assessment of other parameters, should undergo an assessment to exclude any URI and wheezing because these are likely to increase the work of breathing as well as lead to adverse respiratory events. The airway assessment should focus on identifying a syndromic child. If you have to pick out micrognathia, the side view profile of the child is very important. One should look out for macroglossia, hypoplastic mandible, and short neck with its reduced movement. Children are usually uncooperative and cry as well as struggle when separated from parents. This is likely to increase the metabolic rate as well as the oxygen consumption, thereby increasing the chances of hypoxia. Crying also increases the secretions, the airway irritability, as well as the airway edema. All these will increase the work of breathing, which may be already increased due to an active URI and wheezing. Because of this reason, it is very important that children are anesthetized using mask inhalational induction either in the presence of parents or after the administration of oral midazolam. After the child is reasonably deeply anesthetized, an IV line is secured. However, in case of a difficult airway, the IV line should be secured prior to the induction of anesthesia. One should administer sedatives with extreme caution in children with compromised airways because midazolam, although improves cooperation and provides amnesia, it increases the risk of airway obstruction, lengthens the post-operative stay, and also produces more chances of emergence delirium. The children are usually induced with graded concentration of sevoflurane via an appropriately sized face mask. The appropriate size of the face mask is judged by the fact that it should cover the space between the bridge of the nose and the crease of the chin to achieve a good seal. With deepening anesthesia, neck flexion may occur, which is likely to increase the airway obstruction because children have an anatomy which is different in size, shape, position, and composition when compared to an adult. A large head compared to the rest of the body and the rounded occiput and large tongue are the most common reasons for causing airway obstruction. The higher position of the larynx and the neck also contributes. The laryngeal and tracheal cartilages are soft and easily compressed. The tonsils and adenoids will fill the airway, causing obstructive sleep apnea and difficulty in manual ventilation. After sufficient anesthetic depth has been achieved, one should check the ventilation, and for this, the mask holding should be proper. The mask is held with the thumb and the index finger. The little finger should be at the angle of the jaw, and the third and the fourth finger should be free and should not be pressing the soft tissue, and the mouth should be little open. Any pressure of fingers on the soft tissue causes an increase in the airway obstruction by pressing the tongue against the palate or by causing the tongue and the epiglottis to be pushed over the laryngeal inlet. When we are doing mask ventilation, we should try to avoid stomach distension because this is likely to impair the breathing. This is this occurs because the chest wall is mechanically less efficient and because of the horizontal angle of the rib cage, the chest expansion is limited. As the diaphragm descends, it pushes the abdominal contents down and more of abdominal expansion occurs. Therefore, anything that interferes with the descent of the diaphragm will impair the breathing. The extreme flexion and extension of the child's neck obstructs the airway. When you place a pillow or a ring under the head of the infant, it bends his head forward over the chest. It forces his tongue backwards. It makes it harder to tilt the head back for opening the airway, and thereby this worsening the airway obstruction. It is better to place a small roll under the shoulders in a 2-year-old, less than 2-year-old child. If the tongue is not displaced by chin lift jaw thrust maneuver and is very big, then it is better to insert a oropharyngeal airway. The correct size of the OPA is estimated by placing the airway close to the chin, parallel to the mouth, and then judging its location in the mouth. The tip should extend from the center of the mouth to the angle of the lower jaw. A correct sized OPA places the flange outside the teeth or gums and positions the tip near the vallecula. A smaller sized APA places its tip in the middle of the tongue, bunching it up and worsening the airway obstruction. The lingual vein may be compressed and cause tongue swelling. A larger airway protrudes from the mouth and prevents the sealing of the mask over the face. It can fold the epiglottis down over the glottic opening and worsen the obstruction. Prior to attempting an endotracheal intubation, one should understand the peculiar anatomy, airway anatomy of a child. As discussed earlier, the airway of a child is anterior. Its larynx is located high up in the neck, and because of this, it is very difficult to lift the epiglottis by pressing on the hypoepiglottic ligament. The tongue is large compared to the size of the mouth. The neck is short, and there is a smaller distance between the hyoid and the thyroid cartilage. Based on our understanding of the laryngeal anatomy, the type of laryngoscope blade which is selected is also very important. In general, the laryngoscope handle should be thinner, lighter, with shorter blades. You can utilize both Miller and Macintosh blades, and both should be made available. The larger blade should not be utilized because it interferes with visualization and passage of the endotracheal tube, and it may also cause trauma to the oropharynx. Generally, a straight laryngoscope blade is preferred because it lifts the epiglottis, thereby providing a clear view of the cord. If you use a curved blade, it pulls the epiglottis into a closed position when it is pressed on the hypoepiglottic ligament. As you see here, when a curved blade is being utilized, then it is difficult to lift the epiglottis up to visualize the glottis. One can utilize a Macintosh blade to lift the epiglottis just like a Miller blade. The arytenoids and vocal cords they incline anteriorly, causing the endotracheal tube to catch on the anterior commissure when we are inserting it. If you rotate the tube to the right of the or the left, it will allow the tip of the endotracheal tube to slip off the anterior commissure and pass the glottic opening. When the position of the child when you are intubating is very important. Generally, the ear canal should be at level with the sternal notch. Now, since the children have a larger head and they have a larger head, therefore the intubating surface is a little higher up, and this will prevent the laryngeal axis to be in a straight line. A rolled towel under the shoulders will raise the rest of the body, and this will straighten the airway path. The flexion of the head and its rolling can be prevented either by placing a donut, or you can utilize the right hand to stabilize the head while introducing the laryngoscope blade with your left hand. For intubation, both uncuffed and cuffed tubes can be utilized. The preference of one over the other is matter of preference, and it is also a discussion of a lot of debate. Now, how do you select the size of the tube? For children 2 and more than 2 years of age, if you are planning to use an uncuffed tube, the formula age in years upon 4 plus 4 can be utilized. For a cuffed tube, age in years upon 4 plus 3 is the formula which is used, because you require a size 0.5 or 1 millimeter smaller than a uncuffed tube. You should use a cuff manometer for measuring the cuff pressure when you are using a cuffed tube. For a premature infant, you can use a tube size ranging from 2.5 to 3. For a newborn, 3 to 3.5, and up to 1 year of age, size 4. Selecting a correct size of endotracheal tube is very important, because an oversized tube which is introduced into the trachea is likely to cause airway edema and worsen the airway obstruction. This is owing to the fact that the infant trachea, which is about 4 millimeters in diameter, if it becomes edematous, it increases the circumferential area by 75% and increases the resistance by 16 times, as compared to an adult trachea of 8 millimeter, in which an edema of 2 millimeters is likely to reduce the cross-sectional area only by 44% and increase resistance only 3 times. Now, up to what depth should the endotracheal tube be introduced? One can calculate it by a formula which, for more than 2 years of age, is age in years upon 2 plus 12. For children less than 2 years of age, it can be the uncuffed tube internal diameter multiplied by 3. For neonates, it can be weight in kg plus 6. One should be very careful about the potential misplacement of the tube. If you extend the neck, it can cause inadvertent extubation of the of the ETT, especially if it is high up in the neck. If you have used a cuff tube, the cuff of the endotracheal tube will come outside the glottis, and this will present as an air leak. The flexion of the head causes the tip of the endotracheal tube to migrate into the right mainstem bronchus, and this can present as desaturation and increased airway resistance. Now, one should be careful during extubation, just like you have been careful during intubation, and the child should be extubated once his breathing has come spontaneously. You have administered the reversal agent if you have given non-depolarizing muscle relaxants. The breathing is regular, spontaneous with adequate tidal volume. The SpO2 is maintained more than 97%. There is return of airway reflexes and muscle tone, which can be seen by the child folding his legs and moving his hands. At the same time, one should be careful that no laryngospasm is produced. This is which is most likely to occur when you extubate the child mid anesthesia. The supraglottic airway devices are easier to place for an occasional pediatric care provider. It is less stimulating and less traumatic. It can be used as an intubation aid as well as a rescue device. However, one should keep in mind that the seating of LMA may be problematic, especially in children who have large tonsils, and they easily malposition in babies who are less than 1 year of age. It is recommended that supraglottic airway device is introduced partially inflated using a rotational technique or a lateral technique in view of the large tongue. Laryngospasm is also very likely with supraglottic airway device, especially if they are removed in mid-plane of anesthesia. Both first and second generation supraglottic devices are available. The size of the supraglottic device is based on the weight. You can also assess the size to be introduced by comparing the size of the mask with that of the ear, the cushion. It is very important that you understand that pediatric anatomy and physiology is different from adults. It predisposes children to airway obstruction and fast development of hypoxia. Intubation of children requires skill, which needs practice. Selection of correct size equipment and learning correct techniques of airway management is important for a safe outcome. Age less than 2 years is a risk factor for development of respiratory adverse events like airway obstruction, esophageal intubation, and inadequate ventilation and oxygenation, as well as this carries an increased risk of perioperative cardiac arrest. The cleft lip and cleft palate are congenital anomalies with and they are present as 1 in 1000 live births. The cleft palate alone is present in 1 in 2500 live births. About 25% of the cleft lips alone account for six account for the sorry 25% of the cleft lips are present in 60% males, whereas 25% cleft palates are present in 59% females. Both lip and palate are present in 50% of the children, with 70% of them being males. 12% cases are familial and hereditary. The condition is present since birth. Children, especially with cleft palate, present with feeding difficulty, difficulty in swallowing and nasal regurgitation. The teething is delayed or there is malocclusion of teeth. Speech is nasal. There is history of repeated URI, pulmonary aspiration, chest infection, and hearing problems. Now, most of these symptoms are present in children who have a cleft palate. Cleft lip mostly present as a cosmetic problem. During the antenatal period, there may be a history of exposure of the mother to X-ray or intake of drugs like cortisone, diazepam, and phenytoin. There may be vitamin deficiency, and there may be presence of viral infection, especially rubella in the first trimester. In 10% of the cases, there may be associated anomalies like hypertaylorism, hand and foot anomalies, hydrocephalus, congenital heart disease, congenital blindness, and mental deficiency. Cleft lip and palate is associated with many symptoms like van der Wood syndrome, in which there are mucous sinuses of the lower lip. The child may have a Down syndrome and present with round face, protruding teeth, simian folds, severe mental deficiency, hypotonia, and endocardial or other cardiac defects. In Pierre-Robin syndrome, children have micrognathia and glossoptosis. Klippel-Feil syndrome is a condition with congenitally fused cervical vertebrae. And in Treacher-Collins syndrome, there is hypoplasia of the first branchial arch, leading to hypoplastic mandible. Now, embryologically, at about 6th week of fetal life, a depression appears in the front of the head, which is called as the front stomodium or primitive mouth. There is also appearance of 5 processes, a single one at the cephalic end, the frontonasal process, and 2 processes, maxillary as well as mandibular processes. Soon the frontonasal process gets bifurcated into a median nasal process and 2 lateral nasal processes. The median nasal process becomes bluntly bifurcated by the appearance of olfactory pits. The maxillary mesodermal extensions grow medially beneath the olfactory pits to join in the midline, forming the primitive palate and excluding the placode from the upper lip. Now, when one or both maxillary processes do not fuse with the median nasal process, it leads to the development of a cleft which is variable in degree and may be unilateral or bilateral. And bilateral is usually associated with forward displacement of premaxilla and cleft palate. A defective development of the lowermost part of the frontonasal process leads to a midline defect of the upper lip. It is usually associated with chromosomal anomalies like trisomy D syndrome. When 2 mandibular processes do not fuse with each other, there is a defect in the lower lip in the midline. Non-fusion of maxillary and lateral nasal process leads to a cleft which runs from the medial angle of the eye to the mouth, leading to an oblique facial cleft. In this condition, the nasolacrimal duct is not formed. Now, cleft palate is formed by the fusion of two palatine processes, which are a part of the mandibular process. The premaxilla develops from the frontonasal process. Any failure of fusion, partially or completely, of these leads to the formation of different types of cleft palate. Normally, the union commences from the incisive foramen. The extreme anterior portion of the primary palate, the lip and the alveolus, are formed in one process. A failed formation may lead to a cleft which involves part or all of the lip and extends as far back as the incisive foramen. Failure of fusion of two shelves results in a cleft palate, which may involve either soft palate alone or as far forward as the incisive foramen. As I said earlier, that the cleft lip does not interfere with anything like sucking or on speech. However, cleft palate leads to a condition in which the child is unable to suck because the negative pressure cannot be established. Either a bottle or spoon feeding has to be employed. The child with cleft palate is unable to make consonants like B, D, KPT, and has a typical cleft palate voice. His teeth may be maloccluded and his nose is misshapen. Pharyngeal inflammation from the regurgitated fluid leads to inflammation of the orifice of the eustachian tubes, leading to audiometrically detected hearing loss of 10 decibels. Now you can classify the cleft lip and palate based on many classification, and it can be a partial cleft lip or complete cleft lip and alveolus, or a double cleft lip and alveolus, or a cleft of the soft palate. Based on that, modified classification includes a group 1, group 2, 3, and a combination group 1 and 2 lip and palate. The optimum time of surgery differs from center to center. In some centers, surgery is done within 20 to 48 hours after birth because child tolerates surgery better, wound healing is quicker, and because of parent psychology. However, the drawback with this early surgery is that some congenital anomalies like cardiac defect may go unnoticed. The lip surgery is usually done for cosmetic reasons, and it does not interfere with feeding. Palate surgery is done to achieve adequate speech and dentition, and it is usually at 18 months when the speech begins to develop. The earlier the operation, more abnormal is the speech. In India, lip surgery is usually done at 3 months and the palate surgery at 1.5 years. By this time, the child should have regained a normal eating habits. He should have near normal blood volume and normal RBC count. So the optimum tried is thought of as 10 weeks, 10 pounds and 10 gram hemoglobin when the child is showing a steady weight gain, which is adequate for wound healing and safe anesthesia. The preoperatively, the child should be assessed and one should undergo complete medical evaluation for the presence of other anomalies. He should be assessed for anemia and for URI, for undernourishment, dehydration, presence of adenoids and tonsils. URI may be very difficult to control in these children, and therefore, in certain conditions, it may be better to give antibiotics for several days and take up the patient for surgery. The child may have difficult veins for IV cannulation, and therefore, these should be looked for in your preoperative assessment. You can do routine investigations like hemoglobin and urine. Chest X-ray is only required if there is a history of fever, running nose, and purulent secretions indicating infection. In that condition, a throat swab can also be sent for culture. The child should be fasted based on the fasting guidelines of 6, 4, and 2 rule. He can be administered oral midazolam in the dose of 0.5 milligram per kg. In case of a suspected difficult intubation, like in a syndromic child, if you have to give a midazolam, one should monitor the SpO2. One can also give anticholinergic agent glycopyrrolate for its anti-silagogue and vagolytic effect. The children can be induced either by IV induction agents like thiopentone or propofol, or one can do an inhalational induction with graded sevoflurane. One should confirm mask ventilation prior to the administration of a muscle relaxant. If you are suspecting a difficult airway, use succinylcholine in the dose of 1.5 milligram per kg. Otherwise, a non-depolarizing muscle relaxant like atracurium can be utilized. When you are intubating, one should use a tooth guard or a gauze roll to avoid laryngoscope blade from falling into the cleft, and it also avoids trauma to the gums and the lips. RAE tube is the most commonly tube used, and it is useful for cleft lip and palate surgery. One can also use a microcuff RAE tube. A nylon reinforced tube also is non-kinking. The smallest size of it which is available is 13 French, but it leads to an increased airway resistance. The RAA tube is better because it does not hamper the field of vision of the surgeon and is away from the surgical field. It also does not distort the tissues. It provides a secure non-kinking airway because of its preformed curve. When you want to do suction, you can straighten it out. It has two elliptical ports near the bevel, which is a safety measure to provide right upper lobe bronchus ventilation in case of accidental right bronchus intubation. The, the disadvantages of RA tube is that since the curve is preformed, it may not comply with the lip and the chin in many of the children. Secondly, a mouth gap may compress the endotracheal tube. However, it can be avoided by inserting needle caps between the gag and the endotracheal tube. Intraoperatively, one should be very vigilant for the development of many problems which can occur. Number one is that the child may be a case of difficult intubation, especially if syndromic. There may be displacement of the tube, especially after neck extension for the surgical procedure. The pharyngeal pack for the prevention of aspiration can also cause tube compression or kinking. If the mouth gag is malpositioned, it can lead to partial or complete obstruction of the tube. Therefore, whenever a mouth gag is introduced, one should check for breath sounds, look for check compliance, and also assess the airway pressures during placement and manipulation of the mouth gag. There are chances of cardiac arrhythmias after infiltration of adrenaline, especially if you're using halothane as an inhalational agent. In addition to these specific problems, the age group problems like hypothermia and hypoglycemia may also be present. A fluid management plan for any child should address three key issues: any fluid deficit which is present, maintenance fluid requirements, any losses due to surgery, example blood loss or third space losses. The fluid which is required for a child is calculated by Holiday and Seeger's method. Up to 10 kg weight, it is 4 ml per kg per hour. For 10 to 20 kg, it is 40 ml per hour plus 2 ml per kg per hour above 10. And more than 20 kg, it is 60 ml per hour plus 1 ml per kg per hour above 20. All children above the age of 1 month should receive isotonic fluid for replacement of the fluids. Non-dextrose containing fluid is usually recommended in this age group, and blood sugar is maintained with the use of this fluid. The anesthesia should be maintained with oxygen nitrous oxide or using isoflurane, sevoflurane, or desflurane. Intraoperative analgesia can be provided with morphine 0.1 milligram per kilogram or fentanyl 1 microgram per kg. In case of a syndromic children with micrognathia, the nasopharyngeal airway is placed under vision by the surgeon to avoid airway obstruction post-operatively by the large tongue. Now this NPA is then sutured in place. The extubation should be done after removing the pack, under vision suction, and after reversing with neostigmine and atropine or glycopyrrolate. The monitoring which is utilized is ECG, NIBP, SpO2, EtCO2, temperature, blood loss, and fluid requirement. During the recovery, the child should be kept in a semi-prone or lateral position to drain out the blood and avoid aspiration. You should provide an elbow sleeve on the hand to avoid the child touching the wound. One should keep equipment for securing the airway in case of respiratory obstruction and arrest for an emergency. Post-operatively, pain management is by multimodal analgesia using paracetamol of 10 to 15 milligram per kg or fentanyl 1 microgram per kg, and by utilizing nerve blocks. Now, for a cleft lip surgery, usually the area which has to be blocked is supplied by a maxillary nerve, and this supplies the part of the side of the nose and the space between the lower lid and the upper lip. Now, what you do for blocking the infraorbital nerve is that you palpate the palpebral fissure, which usually lies at the midpoint of the pupil and the angle of the mandible, angle of the mouth, and about 7 millimeters from the ala of the nose. Now, after palpating the palpebral fissure, a hypodermic needle is introduced into the infraorbital foramen. Care should be taken that it is not threaded fully into the infraorbital foramen. So basically, you first introduce the needle perpendicular. When you hit uh, the floor of the orbital foramen, you just withdraw the needle and introduce it by a less than 1 millimeter and deposit the local anesthetic solution there. You can use 0.5 ml or to 1 ml of the ropivacaine. The other technique which is utilized is the dental approach, in which the needle is introduced between the uh, gums of the upper teeth, and the needle is directed towards the infraorbital foramen, where a finger is placed so that you can guide that the needle does not get introduced too much in depth. Now, for the palate is supplied by the nasopalatine nerves and by the greater palatine nerve. The greater palatine nerve is a division of the pterygopalatine ganglion, and the other nerve which supplies is the lesser palatine nerve. Now, all these nerves, they supply to the soft palate, hard palate, and the uvula. Now, if you want to block the nasopalatine nerve, what you need to do is you have to introduce a needle from the opposite side in a direction which is towards the molars, and which is towards the molars, and after introduction of the needle for a few millimeters, the local anesthetic is deposited, and this will block the greater palatine nerve. When you want to block the nasopalatine nerve, you have to introduce the local anesthetic at the incisive foramina, and by applying pressure, the local anesthetic supplies the nasopalatine nerve and its branches. One can also infiltrate local anesthetic in the surgical field, and this will block the terminal branches of the nasopalatine and greater palatine nerve. Now, the local anesthetic infiltration in the surgical field distorts the margins of the cleft and makes aesthetic repair difficult. Therefore, most of the surgeons do not like to infiltrate it prior to the surgical procedure, and it is usually done at the end. Now, the post-operatively, the problems which you can face in a child with cleft palate are airway obstruction can occur due to tongue fall if the child is deep, or there can be a tongue edema because the mouth gag has been there for a very long time, the surgery has been prolonged. There may be increased airway secretions, or a throat pack may have been missed. Post-operatively, one should also look out for hypothermia, any vomiting, and pain. The take-home message for this is that cleft lip and palate may be an association with congenital syndromes producing airway difficulty. A vigilant attention to intraoperative problems should be kept throughout the perioperative period so that you have a safe outcome. Postoperative pain relief is an essential component to avoid bleeding oozing from the repaired palate due to a thrashing child. Nerve blocks along with the parenteral analgesics provide optimum analgesia. Thank you very much.